Welcome, everybody. Welcome. Thank you for being here today. This is the second session of the seminar, Thriving in Substance Use Disorders, Service Delivery in the Post-COVID Era. Thank you to all of you for being here today. This is the second session of the webinar that the Center for Substance Use Training and Telementoring, or CSTAT, put together along with the Texas Human Health and Services Commission with the intention of analyzing and exploring the intersection between COVID-19 and substance use disorders. Before we start, I wanted to remind you that this session is being recorded for later distribution. However, the information that you see on the chat and on the Q&A box will not appear on the recordings. That Q&A box is for all of you to drop your questions, comments, or resources related to this presentation today. So please feel free to use it. We will get to those questions later on after this presentation. If you want captioning for this class, all you have to do is navigate to the bottom part of your Zoom window and click on the captioning options. And I wanted to remind you also today we're offering two types of credits. We're offering CMEs and CEs. For CMEs, we'll be sharing a text code in the announcements part of this session. And for Cs, and with that I'm referring, of course, to the certificates for behavioral health professionals, those you will receive somewhere between 15 and 18 days after this class, after you answer the survey link that we will be distributing in the second part of this class. So today we have a very special speaker with us. He is a close coworker of ours here at BWO, Texas, Dr. Chukwuemeka Okafor. Hello, Dr. Okafor. Thank you for being here today. He is an assistant professor at the Department of Medicine and the Department of Psychiatry and Behavioral Health Sciences here at UT Health San Antonio. And we know that his research focuses very much on developing behavioral interventions for persons affected with HIV. Dr. Okafor, it's a pleasure to have you here. Please, whenever you're ready, just introduce yourself and start with your presentation.
Yeah, thank you so much, Andrea. I think you did a good job with the introduction, so that. So what do if everyone can see my screen?
Yes.
Okay, great. The title of my talk today is Stigma, COVID-19, and their impact on substance use disorder, and overdose in the United States. So a couple of disclosures. I guess all speakers and all members of the panel committee have no relevant financial relationship with it or with a commercial interest to disclose. The views and opinions expressed by participants and speakers attending this webinar are solely their opinions and do not reflect the official position of UT Health San Antonio.
Dr. Okafor, I'm sorry, we're not seeing your screen. Are you sharing your PowerPoints? There you go. All right. Okay, so we need now in presentation mode. Perfect. Now we see it. Thank you. Thank you so much.
Okay, so I'll move on to the learning objectives. Here's what I hope the audience will take from today. I hope I would try to make you understand the impact of COVID-19 on substance use patterns and overdose rates in the United States. Second is to recognize the role of stigma in substance use disorder, and overdose. And I'll wrap up by discussing some strategies for reducing substance use stigma to improve recovery. So we'll start with a little bit of data, looking at alcohol use during the COVID-19 pandemic. This data is from a longitudinal study of over 1 million people, and alcohol use was measured using breathalyzers. And if you look at the triangle trend lines here, it shows the proportion of breathalyzers that alcohol was detected, and the square lines are the squares are the proportion of the alcohol use that was detected that was above the legal limit of 0.08 grams per DL. So if you can see from this data, throughout the period of this study, from 2020, beginning of 2020 to July of 2021, there were ups and downs in the patterns of detected alcohol use in this study. Beginning very early in the pandemic, there was a sharp decline. If you remember, the first case of COVID was detected, was announced in March. And so during that period, from January 1, 2020 to March 2020, there was a sharp decline in alcohol detected in this population. And following that, beginning from April to June, there was a sharp increase. So why would there be some decline early on? Well, I guess one could speculate that there was general uncertainty in the population about what changes to expect as the pandemic was beginning to appear that it might be a pandemic. And so during this time, many alcohol establishments closed, and so there were limited access for people to drink. But beginning in April and June, we saw a sharp increase in alcohol that was detected in the breathalyzers. This period likely aligns with when many of the mandatory stay-at-home orders became effective in many states. And so many people found themselves at home, and employment shifted at home. There was work from home. And at some point, people had a lot of free time and began to drink at home. So that was probably what drove this increase in this period. But beginning in June through January 2021, we saw a slow decline in alcohol use. And this period likely aligns with the period where many of the states' mandatory sit-at-home orders began to expire or were lifted or canceled, and people gradually started leaving their homes, and some normalcy was beginning to take place for some people, and there were, I guess, limited time to drink, right? The last period here from January 2021 to July, really, things were beginning to become more normal with the pandemic. People were adapting to the pandemic, and alcohol use slowly increased, but it seems like this increase was likely an increase to what the baseline alcohol use was pre-pandemic. So all to say is that, the pattern of alcohol use during the pandemic was not just a simple increase. It's more like the values high and lows depending on the period of the pandemic. So how about cannabis use? This was data from a national representative study of the US that looked at cannabis use between March 2020 and November 2020. And, you see a similar pattern here, right? Sharp increase in cannabis use during the early periods of the pandemic, and then a reduction, beginning from June, and then a slight increase as well. So there were highs and lows as well in cannabis use behavior during the pandemic. And we saw a similar pattern of this high and lows by sex, by age, and by race and ethnicity. I would point out that the red trends line here for race and ethnicity are the patterns of cannabis use for Black adults in the US. And their pattern seems a bit different from the other groups. And there was a sharp decline, sharper than most groups, beginning from March, and a very modest increase. Well, one could speculate here that, there could have been access issues to cannabis use that were different by race that maybe impacted Black adults in this sample more than the other race and ethnicity groups. But it's hard to tell with this data, but that's just kind of just my speculation here. So in a nutshell, for cannabis use, we see the same pattern, highs and lows during the period of the pandemic. For smoking, we're prefaced to say that smoking has has been on a general decline for over a decade now in the US. Smoking has been reducing in the population. This data is also data from a national representative study of the US adults, and it also shows a decline. The red trend line here, the red line here is the first quarter of 2020, which is when the pandemic hit, and then we can see, a consistent decline, very marginal, but a decline in smoking. And that same pattern, the pattern was the same by most age groups that were looked at in this study. So let's talk about e-cigarette use. So this data is from cross-sectional data of youths and young adults, national representatives data, and caveat to say that we covered a shorter period of time. That was January and June of 2020, and we also see a decline over time, beginning from the March when the pandemic hit. In most age groups, there was a decline in e-cigarette use. Again, similar to what we see for alcohol and cannabis use, general decline in the early parts of the pandemic. Because this study ended in June, it would be interesting to see what happened after June. But we can take a glimpse among this age group, which is those who are 21 to 24 years of age. It seems their e-cigarette use was relatively stable during the early times of the pandemic, but began to increase in May. One could speculate here for this younger age group. During this period, most of the kids were home. There are probably increased parental monitoring, and that the older age group might not have had. And so this group declined, but this group kind of consistent in their e-cigarette use. So drug use. So there's not a lot of data on specific drugs of abuse out there during the time of the COVID pandemic. This is just one of the closest studies I could find, and it grouped all types of drug use as one single category, right? So cocaine, illicit heroin, illicit opioids are all included here. They looked at past 30 days drug use among youths and also at young adults. And for youths, we see a general decline in 2020 compared to previous years. For the older age groups, we kind of see really much consistent or stable. Again, for the younger age group, one could speculate there were increased parental monitoring because most of them were at home, and that reduced their drug use. But because this is just one single drug use category, it sort of masked what else was happening, with other specific drug use, like say, what was going on with cocaine, what was going on with methamphetamine. But again, we're not sure this data is showing there was a decline in drug use during the pandemic years, at least up to 2020. So to summarize, what the data as a variable shows about substance use during the COVID-19. For alcohol and cannabis use, we see a sharp increase during the early times of the pandemic, but as the pandemic, but the prevalence returned to pre-pandemic levels once the shelter-in-place orders were lifted or expired. Data from the pandemic's first year also indicate a consistent decline in smoking and drug use in the population. I'll just say this caveat here. I said it earlier that some of the data here available was limited because it could have masked increases in substance use during the pandemic among certain individuals. For example, some individuals with mental health illness like depression, anxiety, might have experienced increases in their substance use, but because this data is mostly from a general population cohort, we can't see that. And so it'll be interesting to see what the data would look like if it was among, say, people with mental health illness. Okay, so moving on to drug overdose deaths during the COVID-19. So I will start by looking at what the drug overdose deaths were pre-COVID. This is data from the CDC looking at trends in drug overdose deaths by gender, beginning from 1999. And as you can see, that's just a general increase over time in drug overdose deaths, reaching 70,000 or more people in 2019 before the pandemic hit, dying of drug overdose. Overwhelmingly, the culprit really is synthetic opioids or fentanyl. As this graph shows, this graph is looking at deaths by specific drugs of abuse, and as you can see, the dotted trend lines showing this spike is for synthetic opioids, basically fentanyl. We also see problems going on with psychostimulants with abuse potential. They are also increasing, consistent increase over time as well, but again, overwhelmingly it's fentanyl that's driving most of it. Drug overdose death. Looking at it geographically, this data shows the percentage of drug overdose deaths in 2019 involving synthetic opioids and stimulants. The darker shades of blue indicate a higher percentage of drug overdose. So if we focus on the map on your left, which shows the higher percentage of drug overdose from synthetic opioids, you can see that most of the deaths were happening in the Northwest and Midwest regions of the United States, and also Florida here, and some problem in the South as well. The map on your right shows that the percentage of drug overdose from psychostimulants like methamphetamine. Again, we see that the deaths were sort of different from the synthetic opioids, mostly occurring in Pacific Northwest, California, Washington State, Oregon, and then some states in the Midwest, like in the South and Midwest, like Oklahoma and Iowa. But it's important to note that the opioid crisis is a nationwide issue. So overdose rates can vary within different states and localities. So there's general and increasing in drug overdose deaths across most states and localities. So it's important to know that. So what happened post-COVID? Yeah, this is quite sobering, right? This is data from CDC again, looking at drug overdose deaths, including the years of the pandemic, 2020 and 2021. So that number increased from 70,000 to 91,000 drug overdose deaths in 2020, and also increasing further to about 106,000 deaths in a single year from drug overdose deaths. Pretty sobering. And as you can see, there was a significant spike among males. So the drug overdose deaths are hitting males during the pandemic. There was a significant spike in the pandemic years for men. So this is another study from CDC looking at drug overdose deaths by month during the pandemic years. I just wanted to look at that to see how does that align with the substance use data we saw earlier. So this data, beginning from February 2020, the early part of the pandemic years, we saw a significant spike as well. Drug overdose deaths between February 2020 and June 2020. Sharp increase. And it started to decline, but didn't get to pre-pandemic levels. Still had about 7,000 plus people dying every month during the pandemic year. So again, pretty sobering data. Geographically, post-COVID, during the COVID years, drug overdose deaths increased in all states. So the data shaded areas show the states that had, between 40% to 50% increase in drug overdose deaths. And it's important to note that the increases in drug overdose deaths across states were not really confined to the states that are often associated with opioid use, like West Virginia and Kentucky. We saw California here having at least a 40% increase, and Colorado as well, in Washington State. So it's just widespread and everywhere what drug overdose deaths happened in the United States during COVID-19. But when we look at it geographically, percent increase in overdose deaths comparing 2020 to 2019. I think we saw this data earlier. Males had a 33% increase in 2020 compared to 2019. And the younger age group, 15 to 24, were hit hard, right? 40% increase in 2020 compared to 2019. And persons of color had a 45% increase among Blacks and 32% increase among Hispanic. Again, there was increase everywhere, but I'm just pointing out these demographic groups as having some of the really significant increase in drug overdose deaths. So switching gears a little bit, we also had the increased death from alcohol during COVID-19. This is data from the NIH showing deaths that occurred during the first 2 years of the pandemic and that listed alcohol use as a factor in their death certificates, and increased from 78,000 in 2019 to 99,000 in 2020 and reaching 808,000 in 2021 during the pandemic years. Again, sobering. So just one might think about why did all of this happen? Look at the impact of COVID-19 on substance-related and overdose deaths. One is because during COVID, there were disruption of support services, right? The lockdowns and the shelter-in-place disrupted access to substance use treatment programs. And so that drove some of the overdose deaths that we're looking at. Secondly, there was also increased isolation, and people using drugs when they are isolated or alone increases the risk of a fatal overdose. This was another factor that was responsible for the numbers that we're seeing. There was also changes in the drug supply, changes in the purity of some of the drugs. Some of the drugs became more potent, and which will also increase the risk of an overdose. I also point out also that the healthcare system during the pandemics was shifted to be more focused on caring for people with COVID, and so that meant less attention to addressing substance use disorder issues. Then the next data I'm going to show you also gives an example of what I just said earlier. This data is from 21 harm reduction and drug treatment programs in 9 states in the US. And this data is from about 300 individuals. And they asked them the question about what were the receipt of non-medical psychosocial services before the pandemic and after the pandemic. And so the orange bars here are since the pandemic, and the light blue bars here are for before the pandemic. And as you can see, for most of all these services, since COVID, the light blue, there was a lower percentage of individuals reporting that they received these services. For individual counseling, for group counseling with therapists, for consultation with a physician or nurse practitioner across the board. I guess for one of the only thing that increased during the pandemic was overdose education in this study. And one could speculate it may reflect some of the targeted efforts by service providers to address the instability of their patients, what their patients were facing during the pandemic. So this is just the data to show that substance use disorder treatment was disrupted during COVID-19, and that was also a factor in increasing the overdose deaths and substance-related deaths in the United States during the pandemic. So the next slide, I just want to cover some of the public health response to COVID-19's impact on SOD and drug overdose. So as some of you are aware, there was expanded telehealth, state government expansion of telehealth services for SOD treatment and mental health counseling really helped address some of these access issues to SOD treatment. There was also the DA and SAMHSA allowed for take-home doses of methadone and buprenorphine that was prescribed via telehealth. There was also increased funding from the CARES Act support for treatment programs. Some states and localities actually expanded access to naloxone and safe consumption sites and syringe exchange programs, which was a factor in helping to reduce the burden of drug overdose deaths. And there was also some expanded access to mental health services and promoting mental awareness, in some localities as well. So to wrap up here, to consider the future considerations as we move forward, and we recognize that another pandemic is coming. We need to learn from COVID-19, and so one of the things that really helped is the telehealth services, and so we should consider enhancing that, and we should also consider novel ways to ensure that care is continued. Care for people who have substance use disorders continued during public health crisis dynamics. I guess one other thing I didn't really mention much from some of this data is social determinants of health. A lot of employment issues, a lot of income issues are some of the things that drive substance use and overdose. So we should also think about novel ways to address those going forward. Strengthening community support networks are also something that's important to address, isolation among people who have substance use. So looking through the data, I think there's a need for ongoing research and surveillance, more granular data to really monitor trends in drug use and overdose, so that we can use that to tailor interventions to meet the needs of the population. So I'm going to switch gears a little bit and talk about stigma and how stigma, is related to all of this. So the word stigma actually comes from, I read it obviously, actually comes from an ancient Greek language, that means to carve or to mark something as a sign of disgrace or a sign of punishment or shame. And so in modern use now, the mark is used figuratively, referred to stigma when someone sees you in a negative way because of a particular attribute or characteristics, for example, substance use. And this stigma often leads to discrimination, devaluation, and isolation of individuals who have that characteristic. We can talk about types of stigma. There are three broad types. Social stigmas, one, and social stigma is the negative social attitudes that are directed towards individuals with a substance use disorder. Self-stigma is when those attitudes are internalized by the individual with a substance use disorder. And that affects them by increasing their self-blame, and affects them by also reducing their self-esteem. The third type of stigma is structural stigma. And this just represents the institutional policies that limit resources and opportunities for persons with substance use disorder. So we can give some examples of social stigma. One of them is language and labels. How we refer to people with substance use disorder can reinforce some of these stereotypes. So referring to someone as junkie or addict can reinforce self-stigma among individuals. Several examples of social stigma could be employment discrimination, right? We know that individuals with history of substance use disorder face discrimination in hiring practices and workplace, despite their qualification. And this might just reflect because employers may feel that people with SOD are unstable. But all of this reinforce stigma for persons with substance use disorder. The third example of social stigma could be healthcare stigmatization. Providers may hold conscious or unconscious biases against those with a substance use disorder, and which can potentially lead to substandard care, right? Reducing the quality of care for people with SOD, all because of their bias. How about self-stigma? Some of the examples of self-stigma might be shame and guilt, right? Individuals may believe they are to blame for their substance use disorder, and this can prevent them from seeking help or speaking openly about their substance use. A second example could be low self-esteem and self-worth, as I mentioned earlier. When you internalize stigma, it can lead individuals to view themselves as unworthy. And this can further entrench the cycle of substance use, right? Another example of self-stigma could be avoidance of treatment. So when people internalize their stigma, it can cause individuals to avoid seeking treatment for fear of being labeled or further stigmatized, which can also delay their recovery from substance use. Some examples of structural stigma, I guess one is the criminalization of substance use. Substance use is often addressed as a criminal issue rather than a health issue, with individuals facing incarceration instead of being offered treatment and support. That further stigmatizes people with substance use disorder. Another example could be limited access to treatment. Structural stigma can manifest in the form of inadequate funding and resources for substance use treatment programs, which can further reinforce the stigma among people with substance use disorder. The last one is insurance discrimination. Like health policies may offer limited coverage for SOD treatment, or they may impose strict criteria for their coverage, which reflects a structural stigma against this condition. So I guess we can think about and ask ourselves what causes some of this substance use stigma. Well, one factor could be misunderstanding. People often do not understand that substance use disorders are chronic, treatable medical conditions, and that SOD can be effectively treated. So just without knowing this can also lead to stigma. The other thing that could cause substance use stigma is stereotyping and prejudice. When we sometimes see how substance use is portrayed in the media, and it often depicts people with substance use disorder as morally weak or irresponsible or as criminals, and this leads to prejudice and discrimination among people with SOD. Another cause could be moral judgment. Substance use is often seen as a moral failing rather than a health issue. This type of thinking leads to blaming the individuals for their condition, rather than recognizing that SOD is actually a result of changes in the brain that make drug use compulsive. Another cause of substance use stigma could be social isolation. It's true that some people with SOD may engage in some aggressive behaviors or may engage in criminal activity to support their drug withdrawal. And this type of behaviors may cause people with SOD to be socially isolated. from their friends or families, further perpetuating stigma. Another cause that drives stigma is legal and policy issues. Like we mentioned earlier, the criminalization of substance use, and incarcerating people who sought instead of providing treatment and support are things that will further drive or that will cause stigma for people itself. And so how does this type of this type of stigma impact substance use disorder overdose? Well, for one, individuals who need care might not seek it because of stigma. Individuals may also fear revealing their substance use because of substance use stigma. From a healthcare perspective, structural stigma, individuals may receive lower quality care. Individuals may also experience limited access to health programs. And all of this could result in individuals escalating their substance use. So I'd like to just wrap up here by talking about some of the strategies we can use to reduce substance use stigma in our practice everywhere we go. One is, I think our words matter. How we speak about this matters. How we speak about people with SOD matter. We can use neutral or first-person language to address people with SOD. So I have just a short list here. So that's more. But for example, you can, instead of saying someone's addicted to methamphetamine, you can say a person with a methamphetamine use disorder. Instead of using the word clean, so you can use a person is substance free. Instead of using the word dirty, and your urine tox comes out positive, you say it's dirty. Instead of that, we can say persons who test positive for substance use. So there are more examples of how to speak about this that are neutral that could help reduce stigma. One of those strategies to address stigma could be education and awareness. Right, we need to continue to increase public understanding of SOD as a chronic medical condition that is treatable, that is relapsing, but the medications that are effective, and that it's not a moral failing. That's actually changes in the brain that cause compulsive drug use. Right, and we could also increase training for healthcare professionals to recognize their own biases sometimes, and to treat individuals with SOD with compassion and respect. Other strategies is policy and legislation. I think some of you are in the policy field, we should continue to advocate for policies that treat SOD as a health issue rather than a criminal one, and to continue to advocate for legislation that would, provide treatment and support for people with SOD who are in the crosshairs with the law. I think one other approach to address stigma could be the integration of services. Yes, when we promote the integration of substance use treatment with other health services that people with SOD use, that could help reduce stigma. So I guess that's all I had, and the references, and I guess we can address some of the questions you may have.
Thank you so much. Yes, Dr. Okafor. Do you want to start with the questions? Yeah, we can move to the questions if you'd like to.
I see a question about, is this data representative of Texas only or from the nation?
Yes, I can read that for you. Is this data representative of Texas only or from the nation?
Yes, most of the data I showed was from the nation. So.
Right. Someone also added in the question, the Q&A box, is Louisiana not sharing their data? It looks like in a map, the Louisiana area, I'm sorry, was not showing exactly the pattern of usage during COVID-19.
Don't know the answer to that question. If there is no data out there, then it's likely they were not sharing, or data was not available.
Yeah, probably something related to the map at that point, that it was not clear in the map what type or what pattern of use or overdose deaths we're seeing during the pandemic in Louisiana. There's another question for someone here, Dr. Okafor. What should we do differently in a future pandemic to avoid an uptick in overdose deaths like the one we saw in the last COVID-19 pandemic? Good question.
Yeah, I think a combination of what I said earlier, like expanding telehealth services for treatment for SOD, and providing social support for people with SOD, and those two factors could help address those, and also providing medications for SOD via telehealth. So what we already did or doing now, we should get prepared to expand that when there's that public health crisis.
And also someone here is asking if you could elaborate a little bit more on how does COVID-19 and substance use disorder stigma intersect? How we could correlate those two?
Interesting question. I know by itself, I know there was some stigma around COVID early on in the pandemic, and continuing. And I would think that type of stigma for COVID would be even worse among people with SOD. So someone who has a substance use disorder and have COVID-19, it might be layers of stigma that for that individual that could impact them receiving the vaccine or receiving treatment for COVID, but also receiving treatment for SOD. So that's my best guess, but it's a good question.
Yes, and also that leads me to something else that I was thinking about when I was, looking at this very telling data that you shared with us today. What role do you think that harm reduction plays in the amount of overdose death that we have during the pandemic? Because we know that during the pandemic, there was a great deal of isolation, and we know that one of the tenets of harm reduction is never use alone. So there were a lot of people using by themselves. What role do you think that harm reduction played, or harm reduction practices, in the uptick of overdose deaths during the pandemic?
I'd say lack of harm reduction. Lack of harm reduction approaches probably was probably a factor that drove some of the overdose deaths, right? If most of these approaches were not available, that would drive overdose deaths, right?
Yes, and I guess also by looking at your data, it looks like the silver lining in a way, if there could be any in a pandemic, is that after COVID-19, we have seen so much more education initiatives and telementoring programs and people wanting to know a little bit more about substance use disorders. Could you tell us a little bit more about that, and what type of programs you're seeing being implemented that are helping to keep public a little bit more aware and more informed about the seriousness of substance use in America?
Yeah, good question. I'll say one of those is this webinar, right?
Yes.
So this webinar is one, and I think you're right. I think I get a lot of emails as well inviting me to webinars like this to educate about substance use. But there's also increased sort of community events out there that that bring light to this issue of SOD. And there's also some increased funding from the NIH and the CDC to address SOD treatment and support for SOD across board. So I think that's what I'm seeing. That's what I've seen since the pandemic. And particularly for minority populations, that were really hit bad by the pandemic and also by drug overdose. Well, I have seen increased funding from the NIH, increased initiative from the NIH to address, the social determinants of health that drive some of those, issues. So yeah.
Thank you. And also, are we thinking, gosh, I guess this is a little bit of a more complex question that could be broken down in different parts, but do we know of any specific strategies, at least in Texas, statewide, that we are starting, that we are reviewing in case of a future pandemic, so we can, if another pandemic, God forbid, happens, do we have any strategies, any practices that we would like to implement for persons who use substances specifically in Texas?
I hope there is, but honestly, I don't know the answer to that question. But I really hope there is, because the truth is that there's probably going to be another pandemic coming soon. I'm not an agent of doom and gloom, but it's likely to happen again. But I hope that there is some strategy that they're beginning to talk about to implement if a public health crisis happens again.
Right. And we know that in your program research, you focus very much on behavioral interventions for persons affected by HIV. Do you see a parallel, a certain relation, a correlation between what's happening with underserved communities and HIV and COVID-19 in those same communities, that you can talk a little bit more about that? That'd be great.
Yes, we do. So we do. There's data showing increased overdose deaths among people living with HIV. I didn't show that here. There's also data showing disruption of access to treatment for people with HIV. That's actually one data I was looking at a couple months ago that showed that at the population level, in a specific clinic, the viremia for people living with HIV increased during the pandemic. So yes, we're seeing parallels. There were also impacts of COVID on access to treatment for people with HIV, and also impacting the drug overdose deaths as well. Good question. Yeah.
Someone in our chat is asking, are you seeing any particular tendencies or trends in COVID-19 in your practice recently, when your own experience? Any trends in particular that you're seeing, any trends or tendencies that you're seeing on COVID-19 lately?
I think one I'll point out is the issue with long COVID. So long COVID is when people who had an initial COVID infection continue to develop symptoms after many months. And, there is some stigma around that, because some healthcare providers see that as a psychological issue. And that impacts the access to treatment. Though there's no treatment available, but that impacts their access to seeing a healthcare professional. So that's what I'm saying. Long COVID and stigma and access to treatment is something that I'm seeing currently.
And also, I wanted to remind our participants, this is a great opportunity. We have a great infectious disease specialist with us today, Dr. Okafor. This is a great opportunity for any of you to ask any questions or share any resources or comments. So please, this is your opportunity. If you have any questions from Dr. Okafor, he presented us today with some great compelling data, and I think there should be plenty of questions related to COVID-19 and substance use disorders. Oh, someone is asking, do you think it's a coincidence that the drug supply became less safe following the pandemic? Good question. Is it a coincidence that the drug supply became less safe following the pandemic?
Good question. I mean, I wouldn't. Is it a coincidence? I would think. I would answer that. I would think no, because I believe, during the pandemic, there were shutdowns, and presumably those shutdowns affected the drug supply, how drugs were being moved, right? So, I don't know if the question is asking if that was already going to happen. I don't know. But I don't know if that was already the drug supply was going to change regardless of COVID. I don't know, but I think from what we can see from the data with shutdowns and lockdowns, there were disruption to you know, drug movements. And so, yeah, a good question.
Well, I want to thank you again, Dr. Okafor, for taking the time to participate in our webinar. This has been a great presentation. Obviously, there are plenty of questions and resources that could be shared in the future, but thank you for being with us today. It has been very enlightening. I think for now, we can move very briefly to our announcements if our slides are ready. Thank you. And remember, if you want to claim your CME, so you have to do is text code ATTEND 100 95531. That is ATTEND 100 95531 to the phone number that you see on the screen. And that's it. That should do it. You will be receiving your CME. And if you're claiming CMEs, and again, with that, I'm referring to the certificates for behavioral health professionals, please make sure that you answer that survey. We'll be emailing it to you after this class. Give it somewhere between 18 and 20 days for you to receive your certificate. Next slide. And there are still some virtual registrations available for the Texas Substance Use Symposium. It's taking place between February 29 and March the 1st. Please visit texas.org. You still have the opportunity to sign up for any of our virtual classes. Don't miss it. It's a great opportunity for all of us to learn from and network with some great substance use specialists. Next slide, please. And our third session for this same webinar is going to take place on Tuesday, March 26th. Please mark it on your calendars. Dr. Monica Verduzco will be talking about the implications of long COVID in patients with substance use disorders. We were just talking about that during our questions and answers section. So we'll see you all on March 26th. And again, thank you to everybody. Please don't forget to complete that survey. And we will see you on March 26th again. Thank you for your participation. There are many other sessions remaining. So we'll see you next time on March 26th. Thank you to all. Thank you to all. Remember to answer your surveys, please. We'll see you next time. Thank you. We will be mailing the survey in a thank you email right after this session. Please be on the lookout for that, for the person who's asking about the survey. And remember, with the text code, when you text that code that we just shared with you, you will obtain your CMEs. If you have any questions about our symposium, please send us an email at bewelltexas.edu, and we'll be more than happy to guide you through the process. We still have some registrations, some virtual registrations of virtual classes open. Thank you to everybody. We'll see you next time. Thank you.